Welcome to the other side of Letby. In episode 87, we're going to give Dowie Evans some new evidence in case he still hasn't caught on that there is such an abundance of new evidence in the Letby trial that may be the biggest problem that the CCRC has with the appeal or the request to send it back for appeal, that there's so much evidence, new evidence, that I have to go through it all over again. And to do this, we're going to remind ourselves about a case of baby D, and we're going to look at some of the fundamental pathology and physiological mistakes that the staff at the Countess of Chester Hospital made. Now, we're not going to relitigate the whole thing again because I've done a few podcasts on baby D, but we'll pick up on some of the highlights and we'll start the sequence in reverse by looking at the pathology findings and working backwards from that. Now, that would be a typical exercise. If you were doing a case review, you would look at what the pathologist found, because the pathologist is going to be the person most intimately related to abnormal findings in histology. That's the preparation of these little slides and description of the gross anatomy, or the description of each organ that they look at. And we know from many studies that postmortems reveal many more diseases and disease processes than are usually picked up clinically during the course of the patient's life. But we have to start by saying that baby D was a near-term baby, so the baby was 36 weeks plus 6 days, but that is categorized as 36 weeks or preterm. A good weight, 3.13 kilos from memory, and the mother hadn't had any difficulties with the pregnancy until her wires ruptured prematurely. So let's have a look at what the pathologist described when she did the autopsy on baby D. So what the pathologist, Dr. McPartland, who was the person who carried out the postmortem, what she wrote, I think it's a she, but what she wrote was finding of patchy acute pneumonia, most prominent within one of the right lung samples, with some hyaline membrane present. So that's HYALINE membranes present, indicating diffuse alveolar damage. Now, that sounds like a real mouthful, doesn't it? And we'll get to it in a minute. But what is important to understand about this is that baby D survived only 36 hours from birth until death. So what the pathologist is describing here is patchy acute pneumonia. So what is patchy acute pneumonia? Well, pneumonias are usually broken into two categories: bronchopneumonia and pulmonary pneumonia, basically on an anatomical level. So a lobar pneumonia would be a pneumonia, an infection of the lung that's confined to one lobe. And a bronchopneumonia would be a pneumonia that's more disseminated throughout the lung. And we know it's disseminated throughout the lung because it's referred to as patchy. And then the second term used here is acute. So in the case of preterm babies, acute means early onset. So early onset pneumonia in preterm babies can occur within hours of birth, but that is typically as part of a generalized sepsis or septic process. So sepsis, by that we mean that the infection is blood-borne and can actually appear anywhere in the body. But because the lungs are such a big part of the body that receives so much blood, if not all of the blood in the body, the pneumonia would develop from the sepsis. So usually preterm baby, early onset neonatal sepsis within 24 hours of birth is going to be part of a generalized sepsis. Now, the new information that we have since the trial, which Dowie doesn't seem to want to look at, but that he did say in John Sweeney's podcast should have caused the neonatal unit at the Countess of Chester Hospital to close was the presence of the Pseudomonas, this bacteria that can create this thing called a biofilm. And it had been present in the Countess of Chester Hospital in May of 2015, right through to July at least of 2016, so across the whole period. But it was present in the ward from May, meaning that there had to be biofilm, because Pseudomonas would create this biofilm within hours of contamination of the environment, and that biofilm would persist basically until you demolished the building. And so we will recall that baby D's mother's membranes, so that's the protective membranes of the baby, ruptured at home, and they were ruptured for 60 hours according to the mother before the baby was delivered. And of those 60 hours, this mother spent 48 of those hours in the Countess of Chester Hospital with labour being induced, trying to bring on the labour. So I make the argument that she was exposed to the Pseudomonas biofilm for at least 48 hours before birth. Now, the consultants at the Countess of Chester Hospital had to know that that Pseudomonas was there. The junior doctors would not necessarily know it was there, but I can't see why they wouldn't, but not necessarily. It's not their job as such to know what the contamination levels, etc. in the hospital are. That's for the permanent staff, the senior staff, the consultants to know, but they would have known that Pseudomonas was present in the hospital. And the reason we're saying this is because baby D died within 36 hours with pneumonia. And when we say that the onset of the disease would be within hours of birth as part of a generalized sepsis syndrome, we don't mean that the disease would progress the full way to a terminal phase in that period of time. The disease would begin to show symptoms during that 24 hours and generally progress beyond that if the treatment wasn't adequate or if the bacteria wasn't susceptible to the antibiotics that were used to treat the baby. So typically, if a baby had pneumonia, it would not progress this quickly to death within 36 hours. But yet, that is what the postmortem showed. And there are a few clues as to the virulence of the pathogen involved, and they come from the evidence given by Dr. Sarah Rylance. So Dr. Rylance said in her evidence that the baby had jaundice when it arrived in the neonatal unit, which was 4 hours after birth, which was 4 hours too late. Dr. Rylance also confirmed that she wasn't present at the birth and that she didn't know who was present at the birth. So the only description we have of the birth is the mother's description, which I calculated in a previous podcast, gave the baby at best an APGAR score of 1 or 0 at 1 minute. And there's nothing in evidence that the baby was treated by any doctor, but that she struggled to breathe and then collapsed in the father's arms 12 minutes later. And that begs the question, if a baby has an APGAR score of 1 at 1 minute, what is it doing in the father's arms at 12 minutes? Anyway, Dr. Rylance said in her evidence in court that the baby's jaundice was so bad when it arrived 4 hours later in the neonatal unit that they had to put the baby onto triple lights. That means the little light that they use, an ultraviolet light that they use to break down conjugated hemoglobin as part of the treatment of what's called physiological jaundice. So because these little babies are not up and running yet, everything isn't smooth. So we have to remember the bilirubin, which is the pigment that causes the yellowing colour of the skin and the eyes, comes from the breakdown of hemoglobin in the blood, which is a natural process. So a typical red cell will probably last about 2 weeks and then it has to be replaced. That breaks down somewhere in the body and the hemoglobin is released from the cell. it goes to the liver, it's brought to the liver, and it's broken into one of the components is bilirubin. And then this is conjugated, in other words, a piece of sugar, a sugar molecule is attached to it, and that makes it water soluble. And when it's water soluble, the body can excrete it in urine, in feces, but that's how you get rid of it. If it's unconjugated, it's not water soluble. And if it's not water soluble, it's fat soluble, and that means it's neurotoxic. It's toxic to the brain. So the first red flag for baby D that was completely ignored or brushed over or unrecognised by the staff at the County Chester Hospital was the fact the baby needed 3 lamps to treat jaundice in the first 24 hours of life. No baby can have physiological jaundice in the first 24 hours of life. And if the baby has jaundice in the first 24 hours of life, that baby is not a stable baby. So we only need to know that the baby needed triple lights. So that implies that the level of jaundice or bilirubin in the body was up around neurotoxic levels. And that it's not physiological jaundice, that's the normal breakdown of blood that backs up in these little babies and causes them to have a mild jaundice, which you can treat. But it's pathological jaundice, and it's pathological jaundice simply because it appears in the first 24 hours of life. Now, pathological jaundice indicates hemolysis, or the breakdown of red blood cells, running at a very high rate, which overwhelms the capacity of the liver to deal with the degraded hemoglobin. Most of this is going to be unconjugated bilirubin, neurotoxic bilirubin. But the Countess of Chester Hospital staff, Dr. Rylance, a junior doctor, not really her fault, didn't cotton on to the fact that a baby can't have jaundice in the first 24 hours of life. She assumes it's physiological jaundice and puts the baby on triple lights. What she should have done was look for what's called a split bilirubin measurement. And a split bilirubin measurement simply tells you how much of the bilirubin is conjugated and how much of it is unconjugated. And if you get an overwhelmingly high level of unconjugated bilirubin, then you know for definite that you're dealing with a pathological process. And you can do a little test called a Coombs test, COOMBS. And that can be a direct or an indirect Coombs test. And that will tell you whether the red blood cells are being broken down by antibodies in the blood. And if the Coombs test is negative, it means that the red blood cells are being broken down by another process other than antibodies. Needless to say, none of these things were done for baby D. So I'm going to say that the presence of the very severe levels of jaundice within 4 hours of birth or immediately at birth were the first sign of sepsis. It was the beginning of what we call DIC, or disseminated intravascular coagulation. And DIC is basically, due to the sepsis, you start clotting internally, blocking off all these little tiny blood vessels. And this leads to the rapid destruction of red blood cells who run into these little blockages and literally disintegrate. And when we're on the subject of skin discoloration, Dr. Rylance also said that baby D's feet were blue. Well, that's called acrocyanosis, SCROCYANOSIS. And acrocyanosis is also a clinical sign of disseminated intravascular coagulation. Dr. Rylance also confirmed that they made a clinical diagnosis of sepsis, but I don't think they quite realised how bad it was. So we can say that the acute pneumonia either existed on its own, existed along with a sepsis in the body, or indeed they could have been two parts of two different processes. But we have a very rapid destruction of lung tissue, and that's what we mean by the hyaline membrane. And by membrane, we simply mean a biological layer. And this infers diffuse alveolar damage, or DAD for short. And it's a very serious complication. So hyaline membranes are the histological hallmark, you would say, of diffuse alveolar damage. And that's damage to what are called pneumocytes. And pneumocytes are simply lung cells. And there's type 1, type 2 pneumocytes. And the type 2 pneumocytes make the surfactant in the lung. The hyaline membrane, or the DAD, is going to destroy both. So all the grunting and difficulty breathing that the baby had when it was with its mother in the 4 hours before it was admitted to the neonatal unit were in a clinical indication of the diffuse alveolar damage occurring at that stage. And this membrane, this DAD membrane, in hyaline membrane, is made up of dead cells, surfactant, other proteins that deposit along the alveolar walls inside the pneumocytes. So you're destroying the surfactant, you're blocking up all of these little tiny airways that are supposed to be filling with air and exchanging that air, the oxygen in that air, with blood and blowing off the CO2. That's called ventilation. But even in the side room where the mother was before the baby was taken to the neonatal unit, the baby was suffering from diffuse alveolar damage. And we know that has to be the case because this whole picture, this explosive, fulminant picture of very pathogenic bronchopneumonia occurred within 36 hours. And we usually break this down into phases. So the acute phase of a pneumonia is called the exudative phase. E-X-U-D-A-T-I-V-E. And that means that there's exudates, or exits of fluid, coming from these alveoli, or these pneumocytes, into the tissues holding the lungs together and into the lungs themselves. And that's just because the little cells have become so leaky from the inflammatory process that they're damaged and they can't hold the structure of the cell together, and they can't effectively pump out all of the waste that's gathering within them. So it leaks out of these pneumocytes and goes everywhere. And it is literally, when you see it in an adult, it's very fulminant. It is literally the description of a person drowning in their own lungs. Remember that the 4 cardinal signs of inflammation are, in Latin, dolor, pain, rubor, redness, calor, heat, and tumour, swelling. So this oedema, or this fluid buildup in the lungs, is the description of the swelling, the tumour part of inflammation. So it's a very hyper-inflammatory response, very aggressive, very destructive to the tissues around it. And because the baby's immune system is not fully developed, you could expect a degree of that. But at the same time, this, to me, is just far too aggressive. And the exudative phase of acute pneumonia usually lasts between 1 to 7 days. And remember that to create this destruction, we have to have a very strong inflammatory response, which a 36-week preterm baby generally wouldn't be able to generate on its own. And it also gives a lie to the fact that Dowie Evans said under evidence to the jury that the baby had escaped the pneumonia and was beginning to recover on the night of the 21st. That's several hours before the baby died. The presence of the hyaline membrane in the histology sites that were made at autopsy prove that that is completely untrue. We have an overlap here. Generally, we'll have the exudative phase, or phase 1 of the acute phase of pneumonia, coming first, followed by the hyaline membrane phase. Here we have both of them occurring together. There doesn't even seem to be a gap between them, so they're not really phases at all. They're just occurring. You're getting that diffuse alveolar damage immediately, when that really shouldn't be the case. And as I say, you would need a very strong immune system to create that level of inflammation. Now, the typical bugs that would cause neonatal pneumonia, which include streptococci and E. coli, and the reason that they cause pneumonia in these babies with ruptured membrane is because they're colonizing the vagina and the urinary tract in the mother in a natural state. They are pathogens, but we can deal with them if they're confined to those areas of the body. So we have to start thinking outside the box and go, well, it doesn't really sound like streptococcus or E. coli. It doesn't sound like these common bugs are doing this, because they're generally not as fulminant and destructive as onset to death within 36 hours. And we do know from multiple studies that the more pathogenic the bug, so when you start moving into more esoteric type bugs like Legionella, Klebsiella, they're a rare type of bug, that they are associated more with this fulminant course, this really destructive course of disease in the lungs. And Pseudomonas is notorious for causing fulminant neonatal sepsis with an extremely high mortality rate. So that's a piece of evidence that should have been told to the jury. And Pseudomonas is also a pathogen responsible for a wide variety of clinical syndromes in neonatal units, and that includes sepsis, pneumonia, and meningitis. And it's notorious as well for causing a rapid progression to shock and death, which is exactly what we see in this case. We also know from research that when ruptured membranes go beyond 12 hours, and in this case we're talking about 60 hours, Pseudomonas alters the composition of the gut microbes. So these are the little bugs that live in the gut normally. It significantly contributes to dynamic changes in that. And when you backtrack those to the ward, it was always the pathogen that was in the ward environment. So we know for a fact then that Pseudomonas exposure in a situation where you've got premature rupture of membranes is well documented. And that's called a horizontal transmission of environmental pathogens. So the second thing you can have is a direct inoculation. So you could have the baby being exposed directly to the Pseudomonas, but you don't actually need that. You can have the horizontal, which is the movement of the Pseudomonas into the mother's microbe and into the baby's microbe, and infection beyond that. Or you could have a direct infection from the Pseudomonas directly into the baby's blood, which is what I suspect happened here. Now, the other thing that can happen with the common bacteria that cause infections and pneumonias in these little babies with the preterm ruptured membranes, they can combine, particularly the streptococcus, they can combine with the Pseudomonas in the Pseudomonas biofilm and work together to create an even more toxic biofilm that would be almost universally resistant to any commonly used antibiotic. And the Pseudomonas biofilm is capable of supercharging the streptococcus bugs. So even if it was a streptococcal infection rather than a Pseudomonas infection, the presence of the biofilm turns these little streptococcus bugs into even more toxic bugs, that they directly inject toxins into the pneumocytes, the cells of the lungs. And those toxins can create the destruction of the cells on their own without activating the immune system. So whichever of the two, a direct or a horizontal and indirect contamination by Pseudomonas, or the creation of a supercharged streptococcal infection into the mother, results in the same thing: very, very fulminant, progressive, rapid disease that has overlapping phases of development of exudate and hyaline formation at the same time. That's what the pathology is telling me when I look at it. What it isn't telling me is that the baby who has hyaline membrane disease, it has destruction of the alveoli, is a baby that was on the mend. And we know that too from studies that show that babies who have a less pathogenic or a less fulminant type of pneumonia often show the beginnings of signs of recovery at 36 hours. But sadly for baby D was dead at 36 hours. These studies do not show the presence of healing at 24 hours, which is what Dowie Evans is implying in his false evidence to the jury. But I suspect he hasn't looked for these studies, so he doesn't know. So in one study that looked at babies, 7 of the 8 babies that they looked at that were infected with streptococcus, which is the common bug that causes the pneumonia in babies, of the 7 of the 8 babies they looked at did not have the hyaline membrane disease. So hyaline membrane disease is not common in GBS or Group B streptococcal infections. You don't see typically hyaline membrane disease, which is all over the place in the case of baby D. So again, I think that just adds to the reasoning that the fulminant course, the catastrophic course within 36 hours, was much more pathognomic of a Pseudomonas infection than it would be of a typical pneumonia caused by the more common bugs. And then we have the catastrophic management of baby D, which weirdly enough in evidence practically everyone agreed with. But of course, none of this more detailed stuff was put into evidence either, but that means it constitutes new evidence. And also the pathology of the Pseudomonas infection. Now, it's not going to develop a fully coherent picture within 36 hours. Diseases take time to develop to give you a much classical view of what you're looking at post-mortem. So they can be a little bit higgledy-piggledy or mixed up if the course is very fulminant. But Pseudomonas is associated with coagulation in the lungs as well. So this is the DIC, the disseminated intravascular coagulation. That is a well-recognized feature of Pseudomonas disease, and it would explain the onset of the very high jaundice in the early phase of the baby's life, whereas the common bugs that cause pneumonia in babies don't typically cause this coagulation disorder. And the research also says, critically, that the clinical signs of the baby do not correlate with the severity of the pathology at autopsy and may reflect sepsis rather than pneumonia. And when you have that dissociation between clinical signs and actual pathology, that's when the baby could appear to be normal. The two things are not linked. So even though you have this terrible destruction of the lungs, it wouldn't necessarily show clinically. So you would be thinking to yourself, oh, the baby's responding every time we do something, therefore it is only mild disease, or actually it has a very fulminant disease that is only temporarily responding to the treatments that you're giving. And if we look at some of the other evidence that the doctors present during baby D's illness they give us a clue too. So Dr. Rylance tells us that the baby was intubated the night before. So that's on the 20th of June when the baby went to the neonatal unit. The baby was intubated and put on a mechanical ventilator and then taken off the mechanical ventilator at 9 a.m. the next day. But again, we have a note from Dr. Rylance that tells us that the baby was on 40% oxygen and had our old friend 100% saturation, which it shouldn't have had. So it's had hyperoxia as well as the endotoxins, as well as the biofilm, as well as the pathogen itself, causing destruction in the lungs. Dr. Rylance also confirms that when the baby was admitted to the neonatal unit on the 20th, it had marked acidosis. In other words, it had very high acid levels in the blood. She also confirms that the CRP, or the C-reactive protein, or acute phase protein, this is just a measurement of general inflammation, which is not very specific, but it was rising on the night that the baby was admitted to the neonatal unit. And then we have this bizarre decision to take the baby off the ventilator. If there was any point in the baby's life where it was stable or stabilizing, it was when it was on a ventilator. And there are very set conditions under which you would then take the baby off the ventilator. And usually they would unfold over 24, 48 hours, where you're not using so much oxygen, you keep cutting that down. You're not using so much pressure, you keep cutting that down, until the baby, it's clear that the baby doesn't need the ventilator anymore. And then you make the decision to move the baby to CPAP. But they didn't follow those guidelines. They just made a decision, or it appears from the evidence that they just made a decision to take the baby off the stabilising ventilator and move it to the less stabilising CPAP. And the minute they did that, the baby started to deteriorate. So there you have it. The proof of the pudding is in the eating. The minute they took the baby off the ventilator, the baby destabilised or got worse. So they shouldn't have taken the baby off the ventilator. You don't want to have babies on ventilators. You don't want to have anyone on a ventilator. But sometimes you have to have people on ventilators. That's why Dowie would say you have ventilators. And really bizarrely, when Benjamin Myers is questioning Dr. Rylance, he says to Dr. Rylance that she had identified sepsis and acidosis at various points, and during the time she had cared for baby D, required breathing support. And he says that when baby D was taken off CPAP, she began deteriorating, and Dr. Rylance agrees. So not only did these people take the baby off the ventilator to watch it deteriorating and measure it deteriorating with blood gases, they then decided to take it off the CPAP as well. And Dr. Rylance agrees with Benjamin Myers that this baby was very sick. But immediately after that, pop-up prosecutor Simon Driver gets her to change her mind, and he says to her, as of your last review of 7 p.m. on June the 21st, what was your assessment of her at that stage? And Dr. Rylance says, from what I documented, baby D was stable, with minimal respiratory support and no additional oxygen support. She was not a healthy baby at that time, due to still requiring CPAP, but clinically she was stable and making a lot of progress. Sadly, that isn't what the postmortem showed. Postmortem showed that the lungs were being obliterated by the inflammatory acute lung injury that was happening to the baby as a result of what I say was likely Pseudomonas. And you also won't pick up Pseudomonas infections in a routine postmortem if you don't know that you're looking for Pseudomonas, because you need to use different stains, different dyes to bring out the Pseudomonas and the effects of it on the lungs. So it's not going to show up with a standard routine postmortem examination and histology. But then we hit pay dirt, really, when we look at the evidence of Nurse Caroline Oakley. And again, we can't blame Nurse Caroline Oakley for anything, because so far we have had very, very little, if any, input at all from the consultant who's supposed to be in charge of these executive decisions of when to put a baby on a ventilator, when to take a baby off a ventilator, etc. Now, a registrar can do those things, and I've done those things, but generally you would do it when you run it past the boss. So if we look now at the cross-examination of Caroline Oakley, Nurse Oakley, by Benjamin Myers, we find even more horrific news about just how stable baby D was. And we know from the post-mortem and the hyaline membrane disease and the pneumocyte destruction that the baby couldn't have been stable with that level of destruction in the lungs within 36 hours of birth, and it couldn't have been stable because it had very severe jaundice within 6 hours or within 24 hours of birth. Both of those things can't exist with a baby being described as stable. So that's new evidence, if you want, Darry. You can't have a stable baby with both jaundice in the first 24 hours and with those findings on an autopsy. A stable baby who just happens to have its lungs being ripped apart, which you said was evidence of recovery, which it is not. But let's look at what Nurse Oakley has to say. One of the interesting things that Nurse Oakley says, now again, Nurse Oakley is a nurse. She started her shift at 8 p.m. on June the 21st on to 8 a.m. on June the 22nd, during which baby D died. Now, a nurse does not make medical decisions, does not make executive decisions, and I absolutely don't blame any of these nurses for what happened on this ward. But apart from talking about this endless discoloration and never having seen it before, or 20 years of being a nurse and the usual claptrap that ran throughout this trial, when it's a wonder that the baby ever was pink at all at any stage in the treatment of the baby. It was so appalling, the treatment. But if the baby doesn't have sufficient oxygen, it's going to be blue. We think, or I think, that the blue, persistent blue feet were part of a disseminated intravascular coagulation picture. In any way, it doesn't really matter. When Benjamin Myers finally gets to speak to Nurse Oakley, Nurse Oakley admits to Myers that a nursing note from June the 21st during the day states that there were signs of respiratory acidosis after extubation. So we're back being acidotic in the blood again. And this is 9 a.m, after 9 a.m, when they decided, for no reason, an arbitrary decision, to take a baby off life support ventilation. The baby develops respiratory acidosis. So respiratory acidosis is the situation where oxygen is getting into the lungs, but carbon dioxide is not getting out of the lungs. And you say, well, how come the oxygen can get in, but the carbon dioxide can't get out? Well, the oxygen gets in very easily because it has a mechanism to do that. And that mechanism is attaching itself chemically to the heme in the hemoglobin, to the iron molecules in hemoglobin, which are very strongly attracted to oxygen. So it's very easy, even in a compromised lung full of exudate from the lung injury, for the oxygen to get in to the blood. But there is no mechanism similar. There is a kind of mechanism similar, but not exactly similar. There's not the same affinity. So it's much more difficult for the body to get rid of carbon dioxide as it is to take on oxygen. So it's quite easy and quite common to see in people who have respiratory distress or who have exudate in the lung, pneumonia, obstruction to the lung, that kind of thing, that the oxygen level is okay, but the carbon dioxide level is not. It's too high. And when the carbon dioxide level goes high, it turns into carbonic acid in the blood, and you get respiratory acidosis. So even though the mechanisms, respiratory acidosis, metabolic acidosis, are different, the effect is exactly the same. You're creating a situation where the blood is acidic. Now, all cellular functions, they can only function with what's called a base excess, plus or minus, -2, +2, each side of 0. So a very narrow window of acidity in which the body can function. And if it goes beyond those and becomes alkaline, or below those and becomes acidic, then these cells don't function. And they don't function. All the enzymes in the body don't function. The mitochondria doesn't function. Mitochondrial enzymes don't function, the cell walls break down because you don't have any energy anymore. So the minute that the baby is taken arbitrarily from this ventilator, the metabolic system in this baby begins to collapse, and it's compensating then all day. With each little intervention, with each little help of oxygen, the baby's able to hold on. But that's only going to be a temporary state. There's no way the baby can hold on. Nurse Oakley also made an interesting comment that she was using a suctioning device to draw what she said was bubbly saliva from the mouth of baby D. But we have to recall that baby D wasn't feeding. Baby D was not on any oral feeds, and the mother was unable to feed the baby. That was one of the things that really concerned her. So it begs the question, why would a baby who is hypovolemic, so that means doesn't have enough fluid, and they don't have enough fluid because it's leaking into the lungs, why would they produce saliva at all? They wouldn't. They've no need to. There's no stimulation of the salivary glands to make the baby produce saliva because it isn't feeding. And in these shock states where you've got acidosis occurring frequently, one of the first systems that will be affected by that is the endocrine system, and the salivary glands are part of the endocrine system. So the baby will not make any saliva. So what I think Nurse Oakley was referring to was exudate from the lungs coming up, and it wasn't saliva at all. So she was suctioning away bubbly, so that is fluid that contains gas, and the gas was likely either carbon dioxide coming out or oxygen trying to get in. But if you see this bubbly gaseous fluid in the mouth, and I've seen it quite often in people who have heart failure and even in gunshot wounds, things like that, where you've got lung injury, you have frothy, bubbly, bloody, sometimes not bloody, sometimes bloody, exudate coming from the lungs. And you can think, well, this is just saliva, because you have this complete normalcy bias. They are looking at these babies, and all of them have to be normal. They have to be stable. They never seem to question whether or not these babies are truly stable. They don't understand that what they're looking at is compensated babies who appear normal but are in advanced disease states, and we know they are in advanced disease states from the post-mortem. After this respiratory acidosis in the morning of June 21st, Mr. Myers refers to a note continuing with blood gases repeated 2 hours later showed a further deterioration with increasing metabolic acidosis. So this transition from respiratory to metabolic acidosis after the extubation follows a fairly predictable pathophysiological sequence, and it's reflecting a progression from ventilation failures, that's just failure in the lungs, to tissue hypoxia and cellular dysfunction throughout the body. So the disease process starts with the pneumonia and the hyaline membrane disease in the lungs. Now, with the metabolic acidosis taking over from the respiratory acidosis, it's spread throughout the body. And because no one's recognising this at all, we are beyond the point of no return, in my opinion. And the fact that the baby is in respiratory acidosis or has respiratory acidosis is in itself proof that the respiratory support was insufficient. So the decision to extubate the baby was the wrong decision. And this new state of affairs now represents a state that I would say was septic shock in this baby, also probably hypovolemic shock. In other words, there's not enough blood circulating, and there's not enough blood circulating because an awful lot of it has now spilled into the lungs. It's come out of the parenchyma into the parenchyma of the lungs from these little cell leaks that are happening all over the place. So you will have lactates ketone bodies, organic acids, all kinds of byproducts of metabolism building up now because the kidneys are all failing as well. So we now have lung failure, we have kidney failure, we have liver failure now because we can't clear the bilirubin. Baby D is in an appalling state. And all of this starting because the mother shows up and she quite rightly says, my waters are broken, and they send her home and do nothing. Then they take her in, they let her hang around in this filthy ward for another 48 hours and do nothing. They don't give her any antibiotic protection, and you're starting this process of destruction that we're actually seeing now in real time. That's starting, and this is not an event that Lucy Letby was at. This is a real-time unfolding progression from normal healthy state to absolutely appalling disease state. So we are completely decompensating now. We're not able to manage the respiratory acidosis through cellular metabolism. We can't get rid of the carbon dioxide through the kidneys and through the other mechanisms. They're overwhelmed now, and we're starting to build up all of this metabolic acidosis. And then, unbelievably, Myers asked Nurse Oakley, why does he not ask these other people, Dowie Evans and all these? I don't know. But he asked Nurse Oakley, who is the least qualified person to answer him, he asked about the attempt to take baby D off CPAP at 7:15 p.m. So that's 45 minutes before Nurse Oakley comes on shift, and literally 5 hours or so before the baby dies. So we know that the baby failed miserably to come off the ventilator, and now, having failed that, they want to take the baby off the CPAP too. This is a level of care that is inconceivable to me. I have no idea what's going through people's minds. I just don't understand it. And I don't understand how a bluffer like Dowie Evans can go into court in the UK and spout the bullshit that he spouts about air embolism when this is what is actually happening to the baby. Well, jumping back and forth, Myers then says that the pH readings, that's the acid readings, recorded at 10:14 a.m. and 12:10 p.m. on June 21st were 7.194 and 7.173. So getting lower all the time, getting more acidic all the time. 2 hours goes by, more acidic, and heading towards that number 7. If the baby hits 7, it's good night. That's it. And then he says, related to other blood readings, which of course we don't get, but he says that they were not as good at 11:55 p.m. So that is 2 hours or 4 hours almost into Nurse Oakley's shift, as they were at 6:45. So the baby is a 15-hour period now where its ability to buffer acid is completely and utterly overwhelmed. And it is beyond any help at this stage now. So when Dowie Evans says that the baby didn't respond to resuscitation as it should have, there is no way to respond to resuscitation. There is a buffer system within the body, and it has a certain capacity. As I say, it tries to keep what we call the base excess between these two numbers, -2 and +2. And the body is producing acids all the time in the normal course of events, and you have to have that bit of buffering capacity there. But once you overwhelm it, like a battery going flat, or a rechargeable battery going flat, the baby's going to take at least 24, 48 hours to recharge that battery and bring that buffering capacity back up to reserve again. And the baby hasn't got 24 or 48 hours because the baby is dead within 36 hours of being born, which again gives a lie to Evans' claim that this baby was in escape velocity from its pneumonia, whatever term he used. It's the same nonsense that he spoke. There's no way. You're not going to see any improvement in a lung in a baby with pneumonia in a period of time less than 36 hours. And the baby didn't live for 36 hours. So Evans is talking gut rot. And at the time of the post-mortem. The post-mortem is like a freeze frame. In this situation, of course, what will have cleared away in the post-mortem, in the interim, is all of this fluid. All the fluid that was drowning the lungs will evaporate, or most of it will evaporate and disappear. You won't actually see it as bad as it would have been in life. Although sometimes when you see drowning victims, or when you see someone, an adult, who has a very severe pneumonia, bronchopneumonia, or toxin, they breathe in toxins, you actually can feel the water coming out of the lungs when you hold them. So baby D's lungs at the time of death would have been like two sponges full of water, and the gas is trying to get into them. There's no way the gas can get in, and the entire cellular mechanism for energy production in the body is completely destroyed by this stage. Nothing whatever to do with Lucy Letby. And then this clown Evans comes along and he says that due to skin discolorations and other kinds of bullshit that he doesn't even know what he's talking about, this is proof that Lucy Letby somehow injected air into this baby, and that this microscopic action of injecting 5 mils of air into this baby is equivalent to the 15 hours plus of cellular destruction that we've just had described to us by the witnesses in this trial, and also by the result of the post-mortem. And then we have the ridiculous situation where we have another pathologist, Marna Reedy's, coming in and actually saying, looking at the same post-mortem with the combination of the acute pneumonia combined with the hyaline membrane disease, which you would ideally like to see at two separate stages in the progression of a disease. He sees the same thing, and he says the baby died with pneumonia, not from pneumonia. Well, the baby didn't die from pneumonia. Pneumonia kicked off this complete destruction of the lung, which was an inflammatory process, hyperoxia process, same as we talked about last week, endotoxin process, as I suspect, from the Pseudomonas, and the complete and utter failure of anyone to seemingly understand what was actually going on, and that the baby lungs were filling up with fluid, that no stage during the baby's life, the short 36-hour life of this baby, was it ever out of a metabolic acidotic state, either respiratory or metabolic for the most part. It had the one period of respiratory acidosis which came on immediately after it was extubated. So who made the decision to extubate this baby, and why were they not asked in the trial? Why did they make that decision? Because it was a crazy decision to make. The baby should have been packed up, shipped off when it was on the ventilator to a level 3 unit where they would have been able to understand what was happening to the baby, and more importantly, to take actions to stop this getting worse. And I suspect that because baby D was 36 weeks, very near term, when the baby was stabilised on the ventilator, had they shipped the baby out at that stage to the level 3 unit, there is a reasonable chance that the baby would have survived. But once they took it off the intubation, life support and the ventilator, then it was game over. Not only did they do that, they then took it off the CPAP. So they expected a baby whose lungs were full of fluid to breathe on its own. And I just cannot understand how people could be that inept at very basic medicine. This is not complicated stuff. It is very, very basic medicine. So if Dowie Evans thinks that's not new evidence when it is put, if it ever is put to a new jury, he's wrong. It is new evidence. It isn't new opinion, it's new evidence. No baby will survive 15 hours of acidosis at 36 weeks of age. They won't. And that's just the end of it. You are not going to find any expert who's going to come along in a new trial and say that this was an optimum care of the baby. In fact, this couldn't have been a worse example of care. They should go into the textbooks as exactly what not to do in a situation like this. And even the failure to understand that a baby can't be jaundiced within the first 24 hours. They didn't even recognise that. So what can you say about the level of medical care that was going on at the County NHS Hospital? You can't say anything other than it was absolutely abysmal. So I know this stuff can be or sound complicated to people, but it's not. Oxygen in, carbon dioxide out, metabolism and energy production in between, energy distribution through perfusion to the different organ systems, and everything will be okay. If even one of those organ systems starts going wrong, particularly in a baby like this that doesn't have much in the way of physiological reserve to call upon, then you're pretty much swimming against the tide. And for the life of me, I don't understand why the Pseudomonas never made it into the trial, never made it into the Thirlwell inquiry, and no one is talking about it since, because it will supercharge every other bug in the environment to become endotoxin machines that will be able to poison any tissue in the body without even overwhelming it with infection. And our immune systems cannot fight that. We can't fight endotoxins. And so there we are. We leave it there. It's very simple. Don't complicate it. I hope you all picked something up from this, and I hope you learned something from it, and that you can see why someone like me, who is only a generalist, but who did do this stuff in the past and who's read this stuff. This is like third year medicine, fourth year medicine, what you would learn in school. This is at the kind of level that I'm explaining this. It's not at expert level, anything near expert level. We could go into much, much more detail here about cytokines and different things, but we don't need to. It's just simple oxygen in, carbon dioxide out. That's all you need to know. And that wasn't happening in a lung that was drowning in fluid. So, as I say, I hope you got something from this and you learned something and you understand the issues a little bit more. And we'll see you in the next episode. And we'll keep up the good fight in the meantime.